activities before 10 years. So no history of trauma or no history of fever, weight loss, or no history of early morning stiffness, back pain, neck pain, or burning eyes or burning micturition. No history of any bleeding gums. No history of in, weight loss of weight or loss of appetite. Past history regarding the patient. Patient was at 5 years of age. He had developed one episode of fever, which was continuous, and went to Egmore Hospital, where he has been diagnosed doubtful of adenotonsillitis, uh, and got intubated at 5 years of age, which after that a patient got recovered and able to carry out regular activities, and the patient started developing on and off fever in between during the course of life, where he used to visit Ainavaram ESI hospital, which was treated conservatively, and patient felt better and lost follow-up for nearly 8 years. Then after at 2023, patient visited Ainavaram Hospital, where they referred him for further management and specialty management to our hospital, where he has been 2023, where he has been referred to multiple departments and conservatively managed on the surgery department. Visiting surgery department, his mother has been informed that she has some kind of viral disease, so they have taken test for his mother, for him and his brother, and all are started on a single medication. He is on some antiviral medication for past 1 years. The disease is not he cannot convey the actual what's the disease is, but he is taking medication for more than a year. And birth history, his mother has a boy child of two, and one is 18 years of age. He is the second child, 16 years of age, but with normal vaginal delivery, no intraoperative complication or postoperative intubation or nebulization history. Patient was totally normal, sir. Yes, sir. Birth history was normal, and regarding developmental history, no developmental menstrual was normal up to the age. Regarding vaccination history, could not be ruled out from the history, sir. Personal history was patient was normal diet, non-mixed diet, uh, normal sleep pattern, normal bowel and bladder habits, and no history of TB contact with any others or any congenital disease from the family. That's all up to the history.
So at the end of your history, so what you feel it is a problem, congenital nature, is it traumatic?
No, sir, non-traumatic, doubtful of developmental issues.
The main thing is the limb.
Yes, sir. Limp and pain started after 2 years.
So started with painless limb.
Yes, sir.
So painless limb, the episode of started.
Yes, sir.
So apart from the hip problem, any other problem is there?
He is having back pain, sir. But I asked about shortening or other things, sir. Patient myself uh, not worried about shortening.
Hello.
Sir.
Hello.
Any other problem?
So he has no history of clicking, locking, or any other symptoms of the.
Yes, sir.
Hello, am I audible?
Yes, sir.
Yeah. Hi. You are presenting a kid with a onset of symptoms from childhood, actually. So first of all, tell me who's the informant to you, actually, and whether it is a reliable information what you've collected.
Sir,
That's essential. You have to start by telling who is the
yes,
informant.
actually, currently her grandmother is with this child, sir. So reliability is bad only, sir. Then I spoke to his mother, where the reliability is good, could elicit part of the history.
Because everything started somewhere at around 5 years of age, isn't it?
Yes, sir.
So you have to have an informant with a reliable, like who can give a reliable history. Otherwise, it will be difficult. So
Yes,
then you have some history of fever at around 5 years of age, actually. So do you
yes, sir.
think that's part of the etiology of this thing? What's happening now? So are you able to come to
Uh,
some kind of conclusion based on your history? What's happening here for this boy?
yes, sir. Could be septicemia or related account.
So there was history of adenotonsillitis at five
Yes,
years
sir.
of age, actually.
But
So
he
what
has been intubated.
he was
He
into.
has intubated and a tracheostomy scar has been healed at present.
Okay. So was there any reduced movements of limb at that point of time? Were you able to elicit some kind of history like that relating pertaining to that lower limb? Was there any reduced movements?
No, sir. Her parents was able to notice at the nearly at the age of 7, while his walking gait has been changed like that.
So not at the time of
Yes,
fever.
sir. Yes, sir.
So do you know what is a pseudo paralysis?
What do you mean by pseudo paralysis?
Which
You know,
which
pseudo paralysis. You know what is it? So let me tell you, actually, in a child, actually, when there is any pathology going on the limb, actually extremity, like some kind of infection that is going on or some trauma which is not noticed, the child will not be able to move the extremity. So that's called a pseudo paralysis. That is one of the things you have to ask to find out whether some pathology is going on to the pertaining limb. That is one of the thing. Okay. So, and what's the significance of this the illness that you were telling 2 years back, actually? So in around 2022, you were telling, no, he was having
23, sir. Sir,
23.
he has been referred to higher center for management, sir. Where is that time he has been tested for some viral disease, sir.
It's okay.
So
Let's cut it short. So, do you think that has any relevance with this thing that's happening to this boy? The limp and pain, what's going on?
not possible. No correlation.
No correlation. So, okay, what's your like? What's the like? You have to corner what kind of pathology you're dealing with, actually. What do you think? What's happening based
Uh,
on history?
could be could be multi-system involvement, neuromuscular pathology, and developmental pathology. I could have a differential diagnosis of neuromuscular pathology or developmental delay development.
Delayed development. So, like, what's in your mind, actually? So, neuromuscular, what's in your mind, and what's in your mind about delayed development? Any
So
diagnosis specifically you have in your mind?
you said milestones are normal, no?
Yes.
Then how can you say delayed development?
Maybe developmental disorder,
Development.
some developmental disorder.
Which
He was normal during the birth. On while he's while he's growing, he started developing some symptoms, which is manifesting on due course of time.
fever we are suffering at the age of 5. Anything related to that? Anything more in terms of that also?
Yes, sir.
So now you have to rule out whether
Or infection. Yes.
Was there any history of discharge or any surgery in the particular hip?
No, sir. As per history, no discharge or no sinus or nothing or no test has been done.
Hello?
Sir? Yes, sir.
Am I audible?
Yes, sir. Audible, sir. Yes.
Acha. You said
the history start with limb 10 years back, right?
Yes.
What was the nature of the limb? Is it present from the first step, after some step, or is it improving? Yeah, it's increasing, something like that.
Yes, sir. Actually, he's a school-going children able to carry out playful activities. He's been normal, sir. On due course of time, his mother noticed and informed him, and on further growing of the child, he started having back pain and
Nay, I'm
hip
talking
pain,
about
sir.
the limb. Is it present from the first step or after some steps?
From the first step.
Or is it improving or is it deproving?
This
Is
is
there any
progressive.
relevant of this question?
Progressive, sir. Progressive.
Any relevant of these questions
Sir.
with diagnosis? And you said about pain. What's the nature of the pain?
So continuous dull aching type, sir.
Pain on walking, pain at rest.
Yes, sir. Yes, sir. But he has no disturbance of sleep or pain during sleep time, sir. He is having static pain uh, throughout the time, sir, even at rest.
So it's a painful limb. It was a painful.
Able to manage, sir. He is having mild pain, sir. Able to manage with the pain, and he can walk without ambulatory support, sir.
So what could be the possible reason for the painful limb for the last 8 years? You said 8 years, na painful limb.
What could be the reason for the pain?
It's septic causes could be septic pathology of the hip could be there.
Okay, sir. You like let him proceed. Like,
Shall we proceed with the examination?
yeah, we can. So the basic thing is why these questions were asked is because you have to come to like you should guess what's happening actually. So developmental is a very broad terminology, and neuromuscular before taking that into account. So you have to have some telltale signs and points that favors your the way you are going to examine, because based on history also you like we are all like convinced that something what we are guessing is happening in this kid based on the history that is being given. Actually we may be wrong at this point of time, but that developmental term is a very broad term actually. So you have
Okay.
some infective pathology, it can be a post-traumatic pathology, then you have something that's congenital, and there are certain things in this age group actually what you're telling 5 4 years like or some 7 8 year kid, there may be some kind of perthes. We are not telling that, but the differentials may be a perthes, a skiffy, or something that's happening actually. So these are all like everything has some specific history which you have to pick up otherwise. So the limb sir was asking, so you have to tell all these characteristics of the limb yourself. The examiner will not be asking you for one every single point actually, whether it is present from single first step, and whether it is painful, whether it is progressive, okay, whether it worsens at by carrying out activities. All these are relevant actually. Okay, so you
Yes,
can
sir.
proceed please.
So on examination, patient is sounded mind, conscious oriented febrile with thin built and thin nourished, thin built, uh, no pallor, icterus, cyanosis, clubbing, or pedal and cervical lymphadenopathy present, sir.
No, you said any other thing pertaining to pediatric thing you will examine on
Sir,
general examination.
no neurocutaneous marker and hyperlaxity of ligament has been examined, sir. So patient is having a Baton score of 5. He could hyperextension of the distal finger more than 90 degree, and on both side score of gives a score of 2, and flexion of the thumb touching the volar aspect of forearm gives a score of 2 on bilateral both
Yep.
sides, sir.
You demonstrate that.
தம்பி இந்த வரல வச்சு இப்படி ஃபுல்லா தொட அந்த கையில கூட
The-
இப்படி இப்படி இந்த கையில பண்ணு. சுண்டு வரல எப்படி? இரு. அவன் தான் அவனே பண்ணு. இப்படி அந்த கையில பண்ணு. சுண்டு வரல எப்படி பண்ணு. சுண்டு சைடா கட்டு, சைடா கட்டு. நல்லா மடக்கு. அந்த கையில. சரி. And hyperextension of elbow is not present, sir. On bilateral scores gives a score of 0, and hyperextension of knee is not present. Still, score of 0, and in this, and able to touch the floor, sir. முடிஞ்சதோட முட்டி மடக்காம. So gives a score of 1, sir. So patient Baton score is 5 out of 9, sir.
Just touching the floor is not sufficient actually to give one score. Like you have to, the patient should be able to place the palm completely on the floor with straight knees. Okay.
Okay.
I think TK, you can go ahead.
So on examination, patient examined on a standing, sitting, and lying posture. Head in center, neck in center with a tracheostomy scar healed by secondary intention. With the right shoulder at higher level and left shoulder at a lower level. With bilateral nipple. Bilateral nipple at the same line, and no pectus excavatum or carinatum. Flat chest has been seen with the prominence of left sided chest wall, and abdominothoracic type of breathing with umbilicus in midline. Anterior superior iliac spine in standing appears to be at same level, which was compensated by knee flexion on the right side. And bilateral lower limb wasting has been.
So it whether it is at the same level. Focus பண்ண சொல்லுங்க. Where you mark the anterior superior spine. And
Yes.
standing, is it at the same level?
Sometimes changing the patient.
Just you have to tell what is the finding, what is the present finding. You have to not change it. No. So it's not at the same level. No, it is at the
lower level. Right side is lower level, and bilateral thigh wasting looks like thigh wasting more prominent on left side, and knee in center. And leg muscles wasting when compared to right side, with ankle in pronation with calcanea valgus, where the medial border of left foot touching the floor, and right side bunion is present over the metatarsal head, and mild hallus valgus has been present.
So return and show the back also. See from behind.
And exaggerated lumbar lordosis present on the. Okay. Seen and bilateral infraspinatus and supraspinatus wasting been visualized, and more prominence of the right scapula, and kyphoscoliosis. Scoliosis is deviated more on the right side, and paraspinal muscle thick bulk has been more prominent on the left side, with the deepening of the furrow, and right gluteal buttocks region. Right gluteal appears to be more prominent than the left. And wasting of left gluteal muscles been prominently visualized. Dress put. Okar. On sitting, knee, knee is pushed posteriorly when compared to right side, sir. On lying down, exaggerated lumbar lordosis is present, and anterior superior iliac spine more on.
Show that. Ask him to show the exaggeration of lumbar lordosis. கீழே ஃபோக்கஸ் பண்ணுப்பா. கீழே
இந்த பக்கம் மேல காட்டுங்க. Exaggerated lumbar lordosis present, crossing more than the center of midline, and anterior superior iliac spine appears to be left side anterior superior iliac spine appears to be lower level, and pelvic is obliquely placed, not parallel. It is obliquely placed.
So anything you want to change the pattern of presentation, sir? You want to say anything, sir? Here we most of the time we will be presenting our cases only in supine position, and sometimes we'll make them to do the gait at the end.
Okay, sir. Like whatever you practice, we can do like that actually. Please.
Okay, sir. So now I'll ask him to say the salient features on supine position.
Okay, sir. Okay. I think Professor Aditya is also online, so he can also like
yes, join, sir.
Join the discussion actually.
So for Madras Medical College, I welcome him, sir. Welcome, Professor Aditya, for joining with us. Thank you for the opportunity.
You can go ahead, sir, please.
Anterior exaggerated lumbar lordosis present, and anterior superior iliac spine right side appears to be higher level, and left side is lower level. Pelvic is obliquely placed, and thigh muscle wasting and no limb length discrepancy or deformity is present. So coming to examination of proper hip joint.
Yes, you have to tell the attitude of
So
the
first, what will you do? What is your first?
attitude of the patient.
Inspection.
Yeah, inspection. Inspection attitude. You said no.
Yes.
So what's
the attitude of the patient? Lying down, standing, and sitting. What's the attitude of the patient?
What's that?
So sir is asking him to describe the attitude of the patient in in lying down position. Attitude of the limb. Sorry, attitude of the limb.
Attitude of the limb. You
yeah.
You present no exaggeration of lumbar lordosis is there.
Yes, sir. Anterior superior iliac spine left side is appears to be lower level, and the pelvic is obliquely tilted, and no scar sinuses over the hip or thigh, and thigh muscle wasting is present. Knee appears to be facing a corner of the wall with more externally rotated left limb when compared to right, and anklet position of ease, and where the left foot of lateral border of foot totally touching the couch.
Any shortening?
No limb length discrepancy or deformities.
Any wasting?
Yes, the wasting is present over the thigh compartment and the leg compartment over the left side.
So attitude wise, your observation is more externally rotated.
Yes, sir.
How are you saying that there is no limb length discrepancy?
Because
just
yeah.
by inspection.
What are your reference to say there is no limb length discrepancy?
So,
Where will you see for that? If you want to say limb length discrepancy, where you will be seeing the limb?
you should see from the anterior superior spine, sir. But
Ah.
it's been tilted and it's lower, sir.
Yeah.
Somewhere it has been compensated.
Exactly. By you are just now in the inspection part actually. So why you are committing that there is no limb length discrepancy, you are going to describe the level of anterior superior spine, the level of patella and the medial malleolus.
Yes,
And
sir.
you have to say whether they are at a higher level or a lower level when compared to the other side actually.
Yes,
Okay.
sir.
You are not
Yes.
going to tell that there is no limb length discrepancy at the time of inspection. So you have to show us why there is no limb length discrepancy when you're coming to the further part of the examination.
Okay, sir.
So your answer should be like that. I
Okay.
cannot comment because these three level you will be comparing.
Yes.
If that is not sure, you cannot comment on that inspection.
Yes.
So I'll ask him to proceed, sir.
Yeah, and I am not convinced with your exaggerated lumbar lordosis also actually, because on seeing from back also he has a spasm of spinal muscles actually, and it looks flat. But I think the view is like not like we are not able to appreciate that, but I think we can see that further. Okay.
Okay.
So
Yes.
examination of left proper hip joints.
Now you have to say the inspectory finding on the left hip.
Yes, sir.
Yeah. Say that. Then only you go to palpation.
Yes, sir.
You finish at the inspection of the left hip. So at this stage, you can come to a conclusion there is a problem in the left hip.
Yes, sir.
No. So you present your left hip inspection first.
So left anterior superior spine is lower when compared to right with
No, that is
no
over.
visible.
Anterior superior spine is over,
Okay,
man.
okay.
You have to tell what is you are seeing in the inspection of the left hip.
Yes.
Where will you start?
No scar sinuses or discharge from the Scarpa's triangle, sir. Gluteal supratrochanteric hollowness, uh, uh, flattening is present where the gluteus muscle wasting is present more compared to
You
right
will
side.
see gluteal muscle wasting on the lateral aspect.
No, sir.
Then why you are telling? You have to see the trochanter level. Are you able to see that?
Yes, sir. Trochanter is more prominent on the left side
Okay.
and appears to be posteriorly and superiorly displaced when compared to right side, sir.
Okay. Then is it moved up or it is at the same level?
It is highly migrated
When compared to that?
compared to right side, sir.
How do you know that? Inspector.
So on inspection, because of the less muscle density, I could see the bony prominence over the left side, sir.
Okay. Then you come to the inspection of the back. Now,
Yes, sir. Can we go? Can we go? Where dimple of venous could not be visualized, and gluteal muscle, gluteal fold is lost, and no mass or no scar sinuses has been seen. Inspection.
now you come to the palpation.
Yes, sir.
You have to confirm your inspection
Yes,
finding.
sir. Inspectory findings are confirmed by palpation, where exaggerated lumbar lordosis is present by passing the hand which crosses the midline of the spine. And
Just demonstrate. How much is that? So what is the purpose of doing the Thomas test? Why?
whether it's been compensated, sometime hip pathology will be compensated by spine, sir, to rule out whether it's been compensated or there may be having separate deformity of the spine.
So you will
Sure.
flex the affected side or normal?
Normal sides.
Then you are doing affected. Why you are doing?
Sorry, sir.
But demonstrating Thomas test enough. What is the idea of doing this?
So pelvic tilt can be corrected and lordosis will be restored to normal level.
So you are
Exactly, lordosis will be
obliterating
updated.
the lumbar lordosis
Yes.
and assessing what is the amount of
Fixed flexion is available.
so do that. Do that. You have to tell and do demonstrate means. Okay. Yes.
Yes, sir.
What do you do now? How anybody want to demonstrate how to do a Thomas test? Where is Arun Modi? Come demonstrate Thomas test and do. So if you are doing a test, you should know what for you are doing that. What is the purpose
Yeah.
of doing, and you have to do it in a proper way. Okay.
Affected limb.
Thomas
Normal
is
set,
affected
right?
by it.
My now the spine is touching, midline is touching my knuckles, beyond which the pelvis is. I am now the knuckles is trying to elevate from this point. The affected limb is not the angle between the floor and the affected limb is 0 degree. There is no fixed flexion deformity on that.
Then what could be the cause for the exaggeration of lumbar lordosis?
Could be
Lumbar spine exaggeration lordosis. Spine pathology could have.
separate deformity.
So there is no fixed deformity
Yes, sir.
according to your
Hip region.
Thomas test.
Yes, sir.
Yes, sir. So according to Thomas test, there is no fixed flexion deformity. Even though there is an exaggeration of lumbar lordosis, he is not appreciating any lordosis by doing any fixed flexion deformity by doing this Thomas test. So I'll ask him to proceed, sir.
So we are not audible, sir.
Okay. Yeah. Next.
So we could not hear you, sir.
No, he
You-
said
you-
there is a exaggeration of lumbar lordosis. By ask him to demonstrate the Thomas test. By
Okay.
doing the Thomas test, the lordosis is obliterated, but he was not able to demonstrate any fixed flexion deformity in the hip.
Okay. Okay, sir, we can proceed. Let's go to further examination. Professor Aditya is here. Like, sir, you want to make any comments, sir? Please.
Yes, actually, Thomas test consists of two parts. One is you flex the normal hip to reveal the fixed flexion deformity on the affected side. And you can overdo it. So in order to check that, you again try to extend the affected side to come to the level where it again starts going to this thing. So the overcorrection will be revealed. So the amount of fixed flexion you will be able to reveal. Okay. And second thing is, if you are flexing the normal side, you can overdo it so that pelvis starts moving. So you look at the ischial tuberosity on that side. And once ischial tuberosity is in the normal level on the bed, and then you do the second part. So that is the way you can reveal the fixed flexion deformity, Thomas test.
Okay, sir.
Okay, sir.
Thank you, sir. Thank you. So shall I ask him to proceed next? Yes, sir. Yes. Go ahead. Yes, how will you?
Anterior iliac spine, left side is found to be lower, and
So that
no,
indicate what? If the lower anterior spine is at lower level means what does it indicate? There is a deformity in the coronal plane. So how will you find it? Demonstrate. How will you bring it out? You have to square the pelvis, no?
yes, sir.
So
But
do the squaring. So he is abducting and
yes, sir. But fixed flexion,
is there any fixed deformity?
no, sir. Actually, no fixed deformity.
Hmm.
Can,
So what
can
could
you
be the
just explain what you're doing actually? Where you're manipulating both the extremities. So tell us what you're doing for squaring the pelvis.
Squaring the pelvis.
Yeah. How do you square the pelvis actually?
So
What do you mean by
can be square.
What do you mean by squaring the pelvis?
The line of the xiphisternum to pubic spine should be perpendicular to the both anterior superior spine, sir.
Okay, then how are you doing it? How are you performing it actually? You are manipulating both the extremities. Do you manipulate both
Yes,
the
sir.
extremities while squaring?
No, no, no. A single limb can be moved, sir. For this, the patient affected limb is one side, so we can move the single limb itself, sir.
So you are told that
But
the anterior superior iliac spine is at a lower level. So what deformity in the coronal plane are you expecting in this patient?
so, if it is a lower level, it should be abduction deformity, sir. But this patient, I couldn't find any deformity.
You're not able to find any deformity.
Any
It's very
deformity.
important. So is there any other reason why you're not able to square the pelvis in this patient? Like the way it's not behaving the way you are expecting. So could there be any other reason actually?
So, there could be abductor contracture or some
It's a long-standing pathology. So the
pathology.
patient
So
is
there could
having
be abductor contracture, sir. So
abductor contracture. So why you are not able to show that to us if there is abductor contracture? What else? What else? A long-standing pathology. You told that the patient is having a hip pain, back pain, everything. So what could be the other reason actually?
compensation will happen
compensatory
there.
with the spine, sir.
Spine. So
Spine.
what is it called as? So there is a pelvic obliquity, isn't it?
Yes, sir.
So if it's of the pathology is of short duration, it is just a compensation that can be, you will lose it when you can make it disappear actually. Are you able to do that? Whether it is a fixed pelvic obliquity or it's like it is just a compensatory can be corrected. Did you see for that?
No fixed deformity, sir. It's
No fixed pelvic obliquity. How did
yes.
you look for how do you look for fixation of the pelvic obliquity or the spinal compensatory curves, whether they are fixed structural or like they are secondary curves?
Sir, I did that Adams test for the patient, sir. Adams test by bending forward.
Okay.
So I could see the prominence of the from behind. I saw the prominence, sir. So it doesn't disappear, sir. So I
So why do you want to make him
success.
stand? You can just make him sit on the table and see from the back whether the curvature goes off. So when he stands, actually, there is maybe a limb length discrepancy and then the body comes for compensation, actually, the spine. But you make him sit just on the examination table and see whether the spine and the pelvis are like in normal relation. Is there any fixed obliquity now? This is because the duration is 8 to 10 years, actually. There is no fixed pelvic obliquity.
Yes, sir.
Okay. Take it, sir. We can proceed, actually.
It's happening on sitting position.
So comes at the same level.
Yes, proceed.
So bilateral femoral pulses present but decreased when compared to right side. The velocity and the character of the flow is little low, sir.
So now we are coming to the inspection.
Yes, sir.
Palpation.
Inspection.
Palpation.
Palpation
அதான்
to the proper.
கேட்டிருந்தாரு என்கிட்ட.
Sir?
Vascular sign of North is positive, sir. So greater trochanter has been examined, found to
ஆமா ஆமா என்ன பண்ணலாம் இப்படி பண்ணிருந்தோம்.
Some other mic is on actually. So this is not from here.
Please mute for it. Okay. Yes, sir.
has been examined, sir.
அது நல்ல சக்சஸ். அது எனக்கு லேடிஸ் ப்ரோக்ராம் பண்ணோம்.
Yeah, go ahead, go ahead. We have limited time. Please,
Yes, sir.
please.
Greater trochanter has been visualized, sir. It found to be posteriorly displaced and superiorly migrated, where the contour of the greater trochanter appears normal, no irregularity or no roughening of the border, sir.
So are you able to trace the great
Yes, sir.
further? How it is going?
Sir, it is posteriorly and superiorly migrated, sir, when compared to right side.
Is it feeling like a greater trochanter or anything else?
It moves with the rotation, sir. When flexion of the knee, when I move the knee joint, so it moves along with that.
So coming to the palpation of the
Yes, sir.
posterior.
Surface is smooth, no irregularity, no on posterior side I not able to palpate the posterior superior spine, sir, due to pelvic obliquity and where on drawing the Bryan's triangle has been checked.
No. In palpation, what you can do? Something similar to Bryan's triangle. What is that called?
Peritrochanteric tenderness and bitrochanteric tenderness.
No, man. You have to palpate whether the trochanter is migrated or not. That is called as a digital Bryan's. Have you
Yes,
demonstrated the
Yes,
test?
sir. With 3-finger test,
Yeah, tell that. Why not?
with the digital Bryan's, I found to be a little lengthened, sir.
Lengthen.
Yes, sir.
See,
Hypotenuse line found to
the
be
idea of doing the digital Bryan is to know whether the trochanter is migrated up or not.
Yes, sir. It's been migrated up and posteriorly placed.
Demonstrate the digital Bryans. What are the points you will take for that?
Anterior superior iliac spine, greater trochanter, one line facing the perpendicular of the couch, sir.
Okay. So what has happened here?
Here is
So it has both sides. People are watching, no, they also have to know the finding. So one thumb over the
anterior superior iliac spine, one is greater trochanter, one is facing the floors.
Focus the camera, focus that so that online people can watch. கொஞ்சம் slanting பண்ணி காட்டு. So this is the left side. So the distance between your index and your middle finger is reduced.
Reduce, sir.
Yeah. Show it on the normal side.
In the side, right side, right.
He has the difficulty in showing it. So definitely it is more on the right side.
More on the right side. Left side is been decreased.
Okay. Right. So the digital Bryans positive. Okay. So what else?
No peritrochanteric or bitrochanteric tenderness, sir.
So no bitrochanteric
or peritrochanteric tenderness.
Okay. You said already the trochanter is smooth.
Yes,
not
sir.
irregular.
No irregular. Surface is smooth.
Okay, okay, right. So next, anything left out in palpation?
So I did galaxy test, sir, which is found to be with 90 degree of flexion. I could find the knee is displaced. Means left side is thigh is displaced posterior when compared to right side, sir. Ibdi vandu kattu.
So galaxy test is positive.
Yes, sir.
Is it only shortened or it is shortened and down?
So, sir, on placing the hand over the superior aspect, tibial length found to be normal, sir. But on placing the hand to the anterior, it is found that femur is displaced posterior.
So
Thigh segment is displaced posterior.
so the problem is that
Thigh segment, sir.
so anything, sir, you want to say at this stage?
So your history is like he's having pain for 8 years. So you didn't find out the tenderness actually of joint line? Is there a joint line tenderness?
No, he
No,
said
sir.
no joint tenderness.
No, he
But
told there is no trochanteric tenderness. But what about joint line? Did you do that?
that to demonstrate
Sir,
that.
no joint line.
Yeah, you. Achha,
said
there is no
peripheral-
joint line tenderness. No, it's okay. It's okay. If you were told, I would have missed it actually.
Transmitted tenderness. That is called as transmitted. You have to give by trochanteric compression and look for that.
Okay.
Space cut.
Okay. Okay. Professor Aditya, sir, you want to like add any point, please? Your mic is muted, sir. Your mic is muted.
Mike, our start mic. Unmute it.
Yes, sir.
Yeah.
Sir.
So you didn't mention about the Nelliton's line, which is important.
He will come
Uh,
to that, sir.
In measurements, I
He
thought
will
to
come after movement. He will tell about this. Now he is in palpation only. Now he will tell the range of movements. Then measurement. He will come the Nelton's line.
okay. So I
Yes,
thought you have finished the palpation.
Okay. Yes. But what is the
on
movement?
palpation.
Palpation over.
Oh, sir. Coming to movements, sir.
Yeah.
Sir, on flexion,
Make it fast.
first I am telling the normal side compare to the
No, no.
affected side.
Just
A flexion of 140 degree on the normal side, where I could go up to 170 degree on the affected side, sir. Extension is 30 degree on the right side and 20 degree on the left side, where rotation in extension 30 degree on the right side and 60 degree on the left side. Extension in internal rotation where more compared to left side is affected more compared to right side.
So when you are showing the rotation of the hip, you are rotating the foot. You should rotate the thigh only. Okay.
rolling.
Because that will take into account the leg also.
Okay.
Yeah.
Okay.
Supine for log rolling மாதிரி பண்ணுப்பா.
படுக்க வச்சு flexion, hip flexion.
Able to see the video actually. Yeah,
So
yeah.
rotation with
Got
hip
this.
inflection. Where external rotation is 90 degree on the affected side and 70 degree on the right side, sir. Internal rotation 90 degree on the 90 degree on the left side and 70 degree on the right side.
Okay. So all range of movements are exaggerated.
Exaggerated range of movements in all directions, sir.
Measurement.
Measurement.
May I make a comment?
Yes, sir.
So the hip rotations can be examined in hip flexion and hip extension. So he had shown there is a one way of doing in the hip extension. Like you can do in the prone position also, because in the prone position, by keeping the hip extended, you can flex the knee. You will have a lever arm to show exact how much is the hip rotations when the hip is in extension. That is a better way as compared to a supine position, I think so. You can do either way, but the prone position may be a better way because you are flexing the knee. You should have a lever arm to measure correctly.
Yes, sir.
Thank you.
Especially in pediatric cases, we should measure the, do the movement in prone position. Very important.
So external rotation, sir. Left side is exaggerated more when compared to right side.
So both internal rotation.
Yes, sir. Left side is exaggerated more, nearly 90 degrees, sir, when compared to left side. When compared to right side, 70 degrees.
Okay.
And the arm span length is 176 centimeters, sir, where tip of spinous process to single arm length each 78 centimeters. So there is no difference in both sides, sir. Upper segment ratio and lower segment ratio found to be 0.8, sir, where height of the patient is 147 centimeters and weight being 27 kg, sir. And coming to the hip, the length of the limb, true length and apparent length has been mentioned, sir. Apparent length is 86 on the.
How much is the shortening?
Shortening is 3 centimeters, sir, on the left side. Right side, the length of the true length of the limb.
Shortening is
3 centimeters.
Confined to the
hip segment, sir.
Hip segment. Which part of the hip?
Supratrochanteric, sir.
By what examination have you confirmed that?
By Bryan's triangle and Nelaton's line, I have confirmed the.
Nelaton's you cannot make.
Migration has been.
Yeah. Nelaton's line will say whether the trochanter is migrated up or not.
Yes, sir.
The measurement of shortening is
confirmed by Bryan's triangle.
Any other special test you did? What is the gait of the patient?
Looks like be Trendelenburg gait.
I will come to that later. Any special test? Make it fast, but grabbed others time. You have to make it fast. You have to come to conclusion quickly.
Then wasting of the muscle has been seen, sir.
I'm asking any special test you did. You said there is an exaggeration of movement. What test you?
Telescopic test has
been done. Demonstrate telescopy.
Sir, I did the telescopic test. First, I checked the normal side, sir. By comparing, flexing the hip and placing one hand over the anterior superior iliac spine and one hand over the greater trochanter, where I have given a posterior thrust.
Okay. What is it?
I could feel normal on the.
What is the test on the left side, upper side?
Where I could see the
positive or negative?
Positive, sir. Positive.
Keep on dragging. Come on, please. Everybody is waiting, no?
Positive, sir.
Yes, it's positive.
Positive.
Telescopy is positive. Any other thing you want to do? No, you have to?
Trendelenburg test, sir. I couldn't get do the Trendelenburg test because patient not able to stand on single leg, sir, on the affected side. So I go for assistant Trendelenburg, sir. Assistant Trendelenburg is positive where the patient gives more weight on the normal side, sir.
So that means your arm fulcrum
has been changed.
Not in position.
Yes.
Okay, right. What else? Any other examination? Some deformity in the foot.
Yes, sir.
Okay.
Foot, whether I checked whether it's been fixed or not, whether it's reducible or not, sir. But I could feel the ankle could be reducible, can reduce up to plantigrade, but it is slipping externally, sir.
Okay. So calcaneal valgus foot defect.
Yes, sir.
So we are not going deep
Yes,
into
sir.
the foot
Yes, sir.
deformity. Okay. So anything you want to add for the spine?
Yes, sir. I did Adam test, so I could see this is structural scoliosis, where a expansion sees, sir. With inspiration, patient having expansion. 4 centimeter of expansion present over the chest, sir. Without inspiration is 64 centimeter. With inspiration is 68 centimeters. 4 centimeter of inspiration present. And for spine, I did the point and
Okay, now you summarize your finding and tell the only thing is left is the gait.
Yes,
You
sir.
want to say, make him to stand, walk, and tell
Yes.
the gait. So anything you want to add, sir, apart from gait?
So there was a glitch in the internet, so I have missed, I think. So did he talk about the Nelton's line, Shoemaker's line, those parts, sir? Because there was some unstable internet connection here. We are not able to hear those
you just
points.
tell
I
about
don't know
the
whether he had talked about
Shoemaker's
those.
The Shoemaker's line, the line has been intersecting at the
focus on the
right side of the abdomen, sir.
It's below umbilicus or above umbilicus?
Above umbilicus, sir. Mine is slightly above umbilicus on the intersecting at the right side, sir.
Okay.
Below umbilicus. Line passing below umbilicus and intersecting on the right side.
Okay, you can proceed to the gate.
Yes, gate.
So Nelton line has found to be the greater trochanter is superiorly and posteriorly migrated, sir. This is the Nelton line intersecting the scale tuberosity and the anterior superior iliac spine, sir.
Whether you have to
The
flex.
greater trochanter found to be migrated. Nada.
What's the classical description of demonstrating a Nelton's line? Okay, we can discuss later.
Can you tell the kid how he is walking? Is it a painful or painless?
Painless unaided gait, sir. He is
Whether he is moving his body?
He is tilting the whole pelvis and swaying on the affected side, sir.
Just describe the movement. What is happening? What is happening to the shoulder? What is happening to the body? Keep telling, Pa.
Sir, he is swaying the lower pelvis to one side and tilting the shoulder to the affected side, sir.
Is it a stable or unstable gait?
Usually, pelvis should dip down, sir. Pelvis should dip down, but he is having contracture. So it's been compensated. Because of the contracture, he is.
Is it analgesic or not? Its stand space is not that much reduced. So the
appears to be normal. No grimace is seen, and patient is comfortably walking, sir. So no reduction in stand face, equally symmetrically taking steps, sir. So found to be as Trendelberg gait only.
Trendelberg gait. So anything, sir? Any difference of opinion in the gait?
No,
Why you are saying Trendelenburg gate?
Tell.
Sir, lurching on the same affected sides.
See, this lurch looks like to be because of the limb length discrepancy. It's a short limb on the left side. And it is dipping because of that.
So we can say it is a short limb gait, sir?
Yeah. It looks like a short limb gait. The pelvis seems to be the stable. There is no lurch because of that.
Mainly the short limb. That is very obvious. So it is a short limb Okay. Okay.
No, other things is like, what about the neurological examination? Is power is okay on the,
Sir,
because you had in
no, no.
doubt a neural developmental issue also.
Yes, sir.
Was
Power
it
is no, sir. When coming to higher mental function is normal, sir.
no higher
Cranial,
mental function, the power of the extremity?
sir. Power is normal, sir.
Normal. So the
Yes, sir.
question is, so when you observe his gait actually, so the points you told there is a history of pain, but you are now saying that there is no antalgic component in it, isn't it?
Yes,
No?
sir.
Then that should be noted. The other thing is, if you see his gait carefully, he's trying to, like, he's doing a circumtension also. He's not having a heel strike. You make him walk and see.
No, no.
So there is no heel strike. He's just circumducting the limb and getting the limb to progress actually. So apart from, like, there may be a short limb component here, and I feel there is some amount of reduced power also actually. So it's like because of the long-standing pathology. So like maybe we are not able to see it properly here, but these things are to be kept in mind while you are doing a gait examination. You have to talk about the heel strike. Bas beta, it's enough. You have to talk about the heel strike, whether it is not there or not, and you have to tell other things, like you have to dissect the individual joints, whether they are normal, and you have to focus on the hip joint, and you have to see whether the finding is corroborating with your clinical findings. Okay,
Yes,
because
sir.
told there is history of pain, but there is no tenderness, there is no antalgic component, there is definitely shortening, but he also has a pelvic obliquity. Okay, there is a gross increase in range of motion. There is, I think there is positive telescopy, so we expect a Trendelenburg component. Everything is there, so you have to dissect everything. Okay,
Yes,
and tell us what is there. Okay.
sir. Another regarding reflex has been exaggerated in both upper limb and lower limb, sir. Um,
Okay.
biceps, triceps, and supinator brisk over the right side and absent supinator on the left side, sir. And exaggerated knee jerk on the right side and where absent knee jerk on the left side, sir. Where patella and ankle clonosus are present. Babinski is neutral on the left side and
So do you think there is some kind of neurological issue also in this patient?
yes, sir. It feels like some neuromuscular motor neuron disease could be involvement present.
Okay. Dr. Pasupati, I think we have a time constraint actually here, isn't it?
Okay, that's why I rushed up that neurological part and all. I think I will ask him to say the salient features and tell the diagnosis.
Okay, okay. ठीक है.
Summarize your findings and tell what is the diagnosis. Probably make it fast.
So anatomical diagnosis could be unstable hips, sir.
Please understand.
Because of telescopic positive and exaggerated range of motion.
Pathologically,
Could 17-year male boy with unstable hip with some motor neuron disease, sir. Skeletal muscular pathology could be there, sir. With short limb gait, with the Trendelenburg component, with shortening. That's all.
Now, why should a motor neuron disease cause an unstable hip actually here? Why do you want to get that actually? So there are things that may be present apart from this thing actually, but may not be the etiology for this particular thing what you're saying. So how are you corroborating both the things? What motor neuron disease are you expecting? Like, and why do you think this is happening to this particular extremity? If it's a neurological disorder, and you're able to demonstrate neurological findings on the other extremity, why is it pertaining to this hip only actually? So there is some clear history also, like in the childhood. So there may be things, two or three more things that may be present together in a single patient actually, but we are like we want to focus on the hip and its etiology and the other pathologies related to the hip joint only here. So just focus on hip and it's like, what's your diagnosis?
So could be I could have a differential diagnosis. One
Give
could
your
be
differentials if you're not confident.
post septic sequelae. One thing. Second, it could be developmental dysplasia of hip. I could have this too.
So you have a differential of first thing is post-septic and second thing is developmental dysplasia. Why?
Yes,
Why?
sir.
So now you have to tell what are the findings that suggest, like that takes you to the diagnosis to pinpoint between them.
So one thing is on a palpation, the trochanter is highly migrated, superiorly migrated, and telescopic test is positive, and exaggerated range of motion.
When did the limb start, this boy?
At the age of 7, sir.
So in a developmental dysplasia, do you think there will be no limb till 7 years and then it starts suddenly?
Could be late presentation.
Late presentation. Then what about the exaggerated range of motion? Do you see them in developmental dysplasia? Or there will be some restricted range of motion in developmental dysplasia if it is standing for this long duration.
But he is having exaggerated in all directions.
Sir,
you
yes,
mentioned another possibility of post-septic sequelae. So
Yes,
do
sir.
the exaggerated range of motion, they go with the post-septic sequelae?
No, no, sir. But he has been hospitalized and went into ventilator, so could be disseminated infection.
But increased range of motion, they go against the post-septic sequelae.
No, sir. No, sir.
Okay, what else could be the possibility?
Post-hip dislocation.
Suppose if it is posterior dislocation, are you able to feel any abnormal mass in the gluteal region?
Tracing the trochanter, but he was not able to feel any separate mass, sir. He said it is a trochanter itself is migrated up.
Yes, sir.
But it is smooth. So it's probably a dislocated hip.
Yeah. When does the dislocation occur? Whether it is an infant stage or at the age of 7?
That was the question. When it happened, we have to find reason for it.
So
the way in which there is abnormal mobility, it looks more of an infantile problem because of Tom Smith arthritis can present like this. So that is why we want to know whether there was any evidence of infantile infection at a stage of young age.
Sir, asked for history of aspiration around the hip joint or any test has been done, sir. So no history signifies that he had a prior infection and test has been carried out.
Any scar around the hip region?
No, sir. No scar or no sinus.
Okay. No. Thing is, even though there are points favoring old infection, there are certain things which are against it also.
Yes.
So that is why you have to, when you are discussing the case, you have to tell 1, 2, 3 and for and against, because there is no typical confirmatory findings in this case.
Yes, sir.
So that you have to mention in the exam when you are discussing the diagnosis. First thing, one which we can be 100% sure is it is an unstable hip.
Yes,
because of the presence of telescopy and migration of the greater trochanter, severe shortening. That indicates that it is an unstable hip. So, but what is the cause for pathological cause? That is the one which needs critical analysis. So you have to say 1, 2, 3. Why this? Why not this? Like that. That's how you have to discuss.
So post septic could be infection could have altered his biomechanics or progression of the growth plate. So there could
Agreed.
be hip
What is against it? What is against it?
but no prior history signifies any infection over the hip joint during his course of
Yeah.
lifetime.
Suppose if it had occurred at the age of 7, we don't expect so much of abnormal mobility
Yes, sir.
unless it was a destructive dislocation
Yes.
or a distensive dislocation. There are two types, you know.
Yes, sir.
Distensive dislocation and destructive dislocation. So it could be a destructive dislocation, which would have. Is there any acute episode at the age of 7?
No acute episodes, sir.
Yeah.
Is
That
developed
again,
slowly, sir.
that again rules out the possibility of sepsis, isn't it?
Yes, sir. Yes, sir.
That you have to bring in. Okay. What is the next diagnosis you are discussing?
Developmental dysplasia of hip.
Yeah. What is the point against?
The telescopy is positive, sir.
No, that is favoring. That is favoring developmental dysplasia. What is against it? The age of onset is against, isn't it?
Yes,
You
sir.
don't get it at the age of 7.
Well, diagnosed late.
Yes, sir. Diagnosed late and
Is that possible?
usually it's female predominance, sir. But
So what? How can we conclude this, sir? Can it
Yeah.
be?
So we have to conclude by saying that one is unstable hip, pathological anatomical diagnosis, unstable hip. Pathological diagnosis could be septic sequelae. There are points against it also. Could be developmental unreduced developmental dysplasia. That is, there are points also.
Okay. Yes, sir.
So next is we have to go for an X-ray.
So shall we go for the X-ray, sir?
Yes, sir. Yes, sir. Please.
Yeah, what does our Chandigarh people say?
Yeah, could it be paralytic dislocation because of the weakness in the lower limb muscles on the left side and led to this, and that explains the hypermobility at the hip joint. The range of motion is increased. One possibility.
Yeah, I mean, that is a good diagnosis, possible diagnosis, but only thing is we are not able to feel the head in the posterior aspect.
Okay. Yeah, that is
So-
against, but other points are in favor.
Our favor, and one more thing, when he is walking, you could see that exaggerated lumbar lordosis, which also favors paralytic.
Okay.
Yeah.
So it could be either a paralytic dislocation or it could be a developmental dysplasia.
or post
Sepsis is rarely possible
yes,
according to clinical stage. So now we will conclude with the X-ray. What is it? What it is? X-ray will
Yeah.
tell. Yes, sir. So this is the X-ray. Show the X-ray.
Super. System. Sir, solo. So X-ray of
Focus on the X-ray. Full screen focus.
sir, X-ray of skeletally immature individual showing AP view, including lumbar, distal part of lumbar spine, pelvis with both hips and bilateral proximal third middle third shaft of femur, where pelvic is obliquely rotated and tilted, where the Shenton's arc is broken.
Focus பண்ணுப்பா கொஞ்சமா go closer.
Shenton's arc is broken. Head is superiorly migrated
இன்னும்
with
focus பண்ணுங்க X-ray. இன்னும் கொஞ்சம்
dysplastic acetabulum
you keep presenting.
and femur bone is thinned out when compared to right side, and coxa vara is present.
இது எல்லாம் தெரிஞ்ச
Not
Neck shaft length.
coxa vara.
Neck shaft length is sorry. Okay. Valgus when compared to right side, sir.
It is not coxa.
Sir, comment on the X-ray, sir. Anything, sir, you want to say?
Yeah, it doesn't look like to be a coxa vara actually.
Valgus.
Yeah,
So
yeah.
mistakenly said, sir.
Yeah, and the greater trochanter is in fact hypotrophied, and there is the increase in the width of the neck,
Yes, sir.
and head seems to be either it is there is subluxation of the head, or the head apophysis that has migrated. Looks like that. Can we see the lateral view of this?
Sir. That இருக்கப்பா.
Yeah, in lateral view it looks okay.
Yes, sir.
So there is definitely the shallow roof of the acetabulum is there.
Acetabulum is very shallow.
Very shallow.
Yes, sir.
Yeah.
Photo எடுத்து போடு.
So now after the X-ray, what is your diagnosis?
That is a dysplastic acetabulum.
There is a dysplastic hip.
Yes, sir.
There is no evidence of infection here.
Yes, sir.
So the infection is ruled out. Okay. Sir, agreed, sir. It's a dysplastic hip is telling, sir. Anything,
Yeah,
sir?
yeah.
Yes, yes.
It is a dysplastic hip. Only
Yes.
thing is, in the lateral view, it looks as though the hip is well reduced.
Yes. Looks
Probably in the lateral view, hip is the head comes within the acetabulum. Yeah. Okay, we all will agree that it is a dysplastic hip.
yes, sir.
Yes,
And
yes.
the diagnosis is unstable hip, pathological is dysplastic hip. How do you explain the neurological deficit?
He's having some deformity in the spine also, sir. We
Yes,
have
sir.
to.
Yeah.
Separate.
Needs further evaluation. Okay. That is
sir.
how
Yes,
we
sir.
have to discuss in the exam. I will
Yes,
get
sir.
a neurologist opinion. I will do an MRI
Yes, sir.
and MRI of spine. I will do EMG and other things. Okay.
Yes, sir.
So now suppose we know this is a dysplastic hip. What is the age now?
So 16, sir.
16. What will you do
16.
now? 1-6. Okay. What will you do now?
So for the hip,
Yeah, for the hip. Forget about neurology and other things. That will be investigated separately. So now it is a dysplastic hip in a 16-year-old man, boy. What will you do now?
So
so we have to correct
head,
the.
it's should
What
head
is
should
your
be try to be contained, sir. If it is not head is not contained, we will go for a shelf osteotomy, sir. Okay. Go for a
Acetabulum is shadow.
yes,
So you
sir.
have to do some procedure for acetabulum to correct it. Okay.
We'll do osteotomy and bring the tilt the acetabulum, and we'll try to provide the surface area for the acetabulum by reaming also.
Okay.
If it is a bone fused means we'll plan for total.
Sir, Professor Aditya, anything you want to add, sir?
No, no.
Yeah, self operation is one of the option. What are the other options which we can do?
Sir, Kislik procedure.
What is that?
Oh, Chris. Okay. Sir,
What is
Kislik
it?
procedure is open reduction with a femoral shortening and varus osteotomy with acetabular reconstruction, sir.
Yeah, all those things will produce pain. Now he is having painless mobility. If you consider such a major procedure, it will lead to pain.
Okay, sir.
So his problem is instability. Am I right?
Yes,
Yes,
sir.
So what are the other options of providing him stability?
So, since he is mild pain free, we can wait till the bone get ossified, sir. Then plan for total hip replacement.
Yeah, totally again, maybe not worthwhile in a young person. Have you heard of reconstruction of the proximal femur using Ilizarov method by doing Sean's type of osteotomy proximally, and you adduct pelvic supportive osteotomy? Have you heard of it?
Yes, sir.
Yeah, that is also one option. So patient will have young person, unstable hip. All the problems can be corrected with Sean's pelvic supportive osteotomy and treating it by Ilizarov method. You can correct the lengthening and you can achieve the normal mechanical axis. All those things can be done. That is also one option. Okay.
Yes, sir.
So trying to put the hip back in place is not a viable procedure because it can lead to pain.
Yes.
Yes, sir.
Okay.
So
Any
we'll,
other?
yeah, we'll ask the Chandigarh team to sell. Dr. Nirmal, anything you want to add?
No, just I was curious. So in case of patients with even with sepsis actually being treated for other reasons. So that's a very common question we ask. Was the child hospitalized? Was the child with intensive care unit? Because there may be a silent septic sequelae which keeps on lingering and it may present later on actually, just like a dysplasia. One of the things you have to keep in mind is in case of even when post sepsis, the triradiate cartilage fuses earlier when compared to other physes. And what happens is the acetabulum now assumes like it's going to gets becomes more vertical and progressive dysplasia, and it may mimic a developmental dysplasia actually. So and back of my mind, I will not rule out sepsis completely in this case actually, although this patient needs to be evaluated for neurological like etiology also here. So I will just keep it in mind actually. And the other things are like I accept with whatever management that has been discussed. So putting this back, you need a congruent reduction if you want to put it back in. Otherwise, you are going to increase the pain and disability. So for this patient, if it's a painful hip and it's an Ilizarov hip reconstruction, which is a combination of pelvic support osteotomy and lengthening and varization of the distal femur, is a viable option actually for him. Okay, but this patient definitely needs evaluation from neurological aspect. Okay.
Yes, sir. Thank you, sir. I think we exceeded the time limit. Shall we go with your presentation, sir, now?
Yeah, yeah.
What will be your mark to the candidate, sir? External examiner from Chandigarh. You are passing the candidate or what are you doing?
Sir, actually, he has to have a set of things enlisted before he comes for examination. So he should be having a clear-cut idea what are the things he's going to ask and demonstrate. So there is a bit of haphazard thing. I think there is a room for improvement for everyone actually. So like we have to tell him that he has to improve more. I will not tell the result actually, but this is what he has to do. He has to improve more in his presentation and pro forma actually. You should have a pro forma and you should present according to it. Nothing should be missed. The anterior joint line tenderness should be told immediately when you are starting with the palpation actually. You cannot miss it in a hip case. Many things, many things. So you have to practice repeatedly. Okay. There is a room for improvement for everyone, even us actually. So you have to practice repeatedly. Okay.
Sir, good suggestion, sir. Thank you, sir. To go with the short case from your side.
Yeah, he will be presenting, but I would like you guys to lead the questions and examination. Okay.
Yes, sir. That would be better. Yes.
Okay.
Thank you, sir.
Hello, hello.
Yes, thank you, Dr. Prabhakar. You can relax now.
Thank you.
Hello.
Sir, Ramesh, sir. Thank you, sir.
Yeah.
For interaction. I thank Professor Aditya, Dr. Ramesh Babu for contributing valuable suggestions and valuable information for the PG.
Thank you.
Yes, sir. We'll go ahead with the second case, sir, now.
Hello.
Short
Sorry,
case.
I was not for
Hello.
the complete presentation.
Good afternoon, everyone. I'm Dr. Ajit. I'll be presenting the decide case. He's a 12-year-old male child with a chief complaint of left upper limb uh, d- deformity since last 11 months, and he has no other
Sorry to
complaints.
interrupt. Actually, we have a limited time. So as a short case, should he start with the diagnosis as he does in exams, or like he is going to present completely?
He can tell the salient history. What kind of pathology it is? It's a traumatic or anything like that.
Yeah,
After that, he can tell the important
Yes.
findings.
you
Because
start
he can
like
make it short.
exam, tell with the diagnosis, and then you start you show
Yes,
the findings.
Yes, sir. Yes.
Let him say the
Uh,
diagnosis. Yeah.
My diagnosis, sir, is a 12-year-old male child with a left post-traumatic cubitus varus deformity, most probably due to a malunited supracondylar fracture without any neurovascular deficit.
Yeah. So you said it's post-traumatic, no? How old
Sir.
is the trauma?
The patient had a fall with outstretched hand 1 year back when he was taken to a local hospital, and there was a history of manipulation and casting of the arm, and the arm was
No, why do you
immobilized.
say? You were,
Yes, sir. There is a history of manipulation and casting at the local hospital, and the cast was put in for around 1 month time. And after the removal of the cast, the patient noticed the deformity of the elbow in the child, and they took him to another hospital for further management, and he was operated uh, at that hospital. But after the surgery also, the deformity could not improve.
So sorry to interrupt. The
Yes.
question was why post-traumatic? So you have to just answer
Yes, sir.
that question with salient points. Like
Yes, sir.
you told there is a history of fall.
Yes, sir.
Then why do you think it's a significant trauma? The second thing is you have to tell was it a significant trauma or not?
Yes, sir.
So is it a significant trauma?
Yes, sir.
How do you say that?
Yes, sir. According to the history, after the fall, the patient had a acute swelling and very painful elbow with the limited range of motion, and yes, that's why I thought this is a significant that was a
So
significant trauma.
the things that decide the significance of trauma is the limb becomes incapacitated
Yes, sir.
and it requires some kind of intervention.
Yes, sir.
Because every patient walking into your outpatient clinic is going to give a history of trauma. Every
sir.
parent is saying, "Ha, mere bache," that the child had a fall at some point of time. So these two things are very important.
Yes, sir.
One thing is whether it is witnessed. Second thing is whether it is incapacitating. The patient
sir.
is not able to use the limb after the trauma.
Yes, sir.
And the third thing is it requires some kind of intervention.
Yes, sir.
Okay. Yeah. And the other thing you missed in your diagnosis is dominance. Whenever
Yes,
you are
sir.
talking about an upper limb case, you have to talk about dominance actually.
Yes, sir.
Please.
On examining the child, the patient was examined in standing, supine, and sitting position with adequate exposure of upper limbs. The patient has a attitude. एक मिनट खड़े हो जाओ. The patient keeps a limb by the side of his body with the left forearm deviated towards the medial side midline, And on inspection,
Is he
there
able
is,
to get full extension? Sorry for interrupting.
yes, sir.
Is he able to get full extension of the
Yes, sir.
elbow?
Yes, sir.
Show that.
बच्चे
Present up.
हाँ, आप ऐसे इधर हो जाओ, हाँ बस एक बार हाथ सीधा करो, पूरा हाथ सीधा करो, ऐसे हाथ,
Yes.
yes sir.
Yes. So what is there in full extension of the elbow?
Yes,
What
sir.
is the deformity you are seeing?
Sir, in full extension of the elbow, there is
Ask him to extend the other side also.
yes sir, दोनों हाथ करो बच्चे, दूसरा हाथ भी सीधा, हाँ.
Yeah.
In comparison to the normal side, there is a hyperextension noted on the left side. Also,
Sir,
there is a varus deformity of the elbow joint.
apart from your varus deformity, there is a hyperextension as well. So what could be the cause for this hyperextension?
The hyperextension could be, according to the history, he had some trauma. So it could be a malunited supracondylar which has a posterior displacement of the distal fragment, or it could have been a posterior elbow dislocation also. But
So as a result of your posterior displacement, so you
Yes,
mean that fragment is displaced posteriorly?
yes, sir.
That causes the hyperextension.
Yes, sir.
Sorry, like to interrupt. Do you think posterior dislocation will cause hyperextension at elbow? You are running very clearly, actually. You're telling very clearly. Then why do you want to bring that diagnosis here? What happens in posterior dislocation?
Why the hyperextension is there? Can you explain that?
Sir,
What has happened to the distal part of the humerus?
Yes, sir. The distal humerus fragment has migrated proximally and posteriorly, sir.
And what else has happened?
Hanji, sir.
And what else has happened? There is a posterior migration, superior migration, but what else has happened to the distal part of the humerus?
It was the commonest type of supracondylar fracture.
Sir, posteromedial type, sir.
Angulation, commonest type of angulation.
Angulation is, sir, lateral angulation with the
So relax. It's whether it's flexion or extension.
extension type, sir.
So that's
Extension type.
Be cool in your exams.
Yes,
Okay.
sir.
Extension. Okay. So is it posterior displacement or a posterior tilt actually? What's causing this extension? If it is a supracondylar, that's the question.
Posterior tilt, sir.
Okay. So don't bring posterior dislocation of elbow into this diagnosis. So it's going to be a flexion deformity. So that's not going to cause hyperextension.
So
Okay.
in addition, there will be limitation of flexion.
Yes, sir.
So
It
you
is
understand?
demonstrable. Yes, sir.
Yeah, movement at the elbow is normal,
Yes, sir.
but because of the angulation and tilt, the flexion is limited
Yes, sir.
and extension is increased. Okay.
that will
It
be
is
always
demonstrable in this patient, sir. There is increased extension and there is decreased flexion of the left elbow. बच्चे हाथ मोड़ो दोनों पूरा मोड़ो मोड़ो ऐसे. As we can see, there is around 110 degrees of flexion on the left side, whereas on the right side it is around 130 degrees. In fact, 140 degrees.
Yes, that 20 degree has gone into the hyperextension.
Yes, sir.
Okay.
So then, what could be the reason for your cubitus varus deformity?
Yes, sir.
Why you are getting that? Why you are getting that cubitus varus deformity in this case?
Sir, because the on full extension of the elbow, there is a medial tilt. There is medial deviation of the forearm.
Yeah, that is agree. You said
And what else?
Middle deviation. What else?
So can you tell what components are contributing to the varus deformity?
Yes, sir. The components contributing to the varus deformity is the lateral angulation of the elbow, the medial tilt, the medial displacement of the distal fragment, and the posterior tilt.
No. There is another component. There is the internal rotation of the fragment.
There is an internal rotation. Okay.
Yes, sir.
So how will you know there is a exaggeration of internal rotation is there or not?
Sir, I would like to examine the shoulder joint also. दोनों हाथ ऐसे करो बच्चे, दोनों हाथ ऐसे करो, मोड़ो. इसको पूरा पीछे लेके जाएंगे, दोनों हाथ ऊपर. Sir, on external rotating the shoulder, there
Yes.
is limitation of external rotation on the affected side,
Yes.
whereas on doing the internal rotation, there is exaggerated movement of internal rotation on the affected side.
Is there any better method to demonstrate this at the
Yes, sir.
shoulder?
Yes, sir. There is a special test called Yamamoto test. बच्चे आगे झुकेंगे, थोड़ा सा आगे झुकेंगे, दोनों आगे झुकेंगे, दोनों हाथ पीछे. I'll extend the shoulder joint and then I'll try to internal rotate the shoulder further. But on the normal side, I am not able to internal rotate beyond the horizontal plane. But on the affected side, there is increased internal rotation. The forearm is pointing upwards as compared to the horizontal plane.
Yes.
Continue with your examination.
Yes, sir. On inspection of the child, there is both the shoulders are on the same level and the head lies in the center. On inspection of the arm, there is wasting of the arm muscles noted, and there is a scar mark of around 5 centimeter on the posterolateral aspect of the left elbow, and the forearm muscle bulk also looks wasted on the left side. There is wasting of the thenar eminence also prominent on the left side, on the affected side. On further examination, I did the palpation. On palpating, there is a irregularity of the first of all, there was no local rise of temperature and there was no tenderness on the joint.
If
And
suppose there is a local temperature is more,
yes, sir.
what do you think of this case?
If the local temperature is more, then I will there can be a septic etiology of the matlab, deformity.
No,
Is it common in a closed
the patient
fracture?
went to a traditional bone setter
Yes, sir.
and there is local increase in temperature. What else could be there actually?
There can be myositis ossificans also if there is a history of massage, but there was no history of massage. He went to a local hospital and he was casted. There was no local massage history.
Yes.
On further palpation, I could appreciate irregular and thickened supracondylar ridges on the medial as well as on the lateral side. I could palpate 1 centimeter by 1 centimeter lump, bony hard lump on the posterolateral aspect of the humerus. There was no tenderness of the olecranon, medial and lateral epicondyle, and there was no neurovascular deficit appreciated. On हाथ से पर रखें बच्चा. On palpating the medial, lateral, and epicondyles and the olecranon, I could appreciate that the 3-point bony relationship is maintained bilaterally. It is comparable on both sides, so it is
Is
not
it
disturbed.
equal? Is it
Yes,
equal
sir.
on both sides?
Yes, sir.
So it's not altered.
Yes, sir. It's not altered. It's comparable on both sides, sir. I measured it. हाँ जी, sir.
The extension of elbow.
Yes, sir.
In extension also
Yes, sir.
mention
सीधा करो.
about three bony point relationship.
घूम जाओ. In extension, also the 3-point bony relationship lies in a single line on the normal as well as the affected side.
So what does it confirm?
It confirms that the etiology or the trauma has not caused intra-articular pathology. The pathology most probably is located proximal or distal to the joint.
To be precise, you can mention that there is no dislocation of the elbow.
Yes, sir.
Okay. Yeah.
Anything you palpated at this stage?
Sir, I palpated a 1 by 1 centimeter lump posterolaterally beneath the scar mark of the patient, which is
Did
bony
you
hard,
palpate
which is
any,
bony hard in consistency, sir.
any soft tissues there around?
No, I palpated the ulnar nerve, sir.
Ah.
Rest.
Looks normal.
Yes, sir.
No
It is mobile, no hypertrophy, or there was no tingling, or there is no signs of tardy ulnar palsy in the patient.
Okay. So what else? Any other important thing you will ask in the history? The deformity you said no?
History, since the patient has a unilateral pathology, so I would like to
regarding the deformity, you should know whether it is a
the deformity. I asked about the progression. The deformity is static. It's not progressive since last 11 months when the parents first noted the deformity. Also, I asked about any
significant or not to ask whether the deformity is static or progressive. What way it is important?
Sir, it could differentiate from my differentials. Supracondylar fracture will most probably have a static deformity, whereas if it was a lateral condyle humerus fracture, the deformity could have been progressive, or if the history had been congenital, then also it would have been progressive.
Yes.
Do you think
One important point you have missed. Can you mention about the shortening of the arm or forearm, which is important in such cases?
Yes, sir.
Is there any shortening of arm or forearm?
Sir, the upper segment, the arm segment was almost similar, almost comparable. It was 0.5 centimeter shortened on the left side, on the affected side. The forearm segment of the upper limb was equal bilaterally.
So minimal shortening.
Yes, and minimal shortening in the arm segment of the upper limb.
Okay.
Coming to the question of whether it is static or progressive, the first thing you have to say in progressive is a trochlear avian, actually.
Yes, sir.
Okay. Second thing, medial growth arrest and lateral growth, like it's like in a distal humerus, what's the percentage of growth contributed by distal humerus in the entire humeral growth? And up to what age it is significant? So that's why we say cubitus varus it's not going to progress or it's not going to regress, actually, isn't it? So what's the percentage? You should know this.
I don't know, sir.
It's only 20%. And after 6 years, it's not much growth left there, actually. So that the most important thing you have to find out is a trochlear avian, actually. Okay, because it may lead to early onset osteoarthritis. That should be kept in mind. Okay.
Yes, sir.
Yes, sir.
So, how will you manage?
Sir, I would first like to investigate with the radiograph and some routine blood investigations.
How the routine investigation is important in managing in the management. First, you have to see some important investigation. What is that important investigation in your management?
Sir, I would like to rule out infection, although it is not evident by history and examination, but I would like to get a complete blood count with the total lymphocyte count and ESR and CRP values of the child to rule out infection. Then I'll also like to do serum calcium and vitamin D levels, also a level of PTH.
What about X-rays?
Yes, sir.
Hey, you do see a PTH and all in a routine cubitus varus case? No need to tell all those things if they ask like what will you do further, what will you do further. Tell what you do. You have to take an X-ray, isn't it?
Yes, sir.
Huh?
The X-ray shows a bilateral upper limb scanogram of
No,
male patient.
before commenting on that,
Yes, sir.
can you tell what X-ray you will order in such cases?
Yes, sir. I would like to order a dedicated left elbow AP and lateral radiograph. Also, along with that, I will like to order a bilateral upper limb scanogram to compare for the deformity on the normal side, to calculate the angular deformity on the affected side and compare it with the normal side.
Is it elbow X-ray or something else?
Sir,
You should
elbow
get
with
the
distal
X-ray
humerus,
of the distal humerus
distal humerus
with
along with
elbow.
proximal forearm.
With elbow, yeah.
Yes, sir.
And AP and lateral should be according to the distal part of the humerus.
Yes,
Okay.
sir.
And both sides.
Yes, sir.
Okay.
This is a AP and lateral projection of the left elbow of a skeletally immature patient with within some implant in situ. Most probably was done during according to the history, when he was operated 11 months back. On the AP projection, I could appreciate two screws being connected with some with a wire, and I could also appreciate the Bowman's angle, which is increased, and I could appreciate that the physeal line is present at the head of the radius. On the lateral projection, I could confirm my findings, and I could appreciate that although I'll need a proper measurement, but I could appreciate that the anterior humeral line will not intersect the capitulum. It is most probably going to pass anteriorly.
What was the surgery done for him?
So the surgery most probably looks like a French or modified French osteotomy, which was attempted.
So comment on that. The X-ray shows they have done some surgical procedure.
Yes, sir.
So what made them to present again with the same deformity and problem is not corrected?
Sir, both these screws look in different planes, so they have most probably done a modified French osteotomy.
Yes.
They have attempted to address the rotation of the deformity, but the angulation has not been corrected because
Any comment on the trochlea, medial condyle?
the trochlear borders look irregular, sir. It is
Is it normal or abnormal?
looks abnormal, sir.
What is the age of the patient?
Age of the patient is at 12 years, sir.
So by this time it might have formed well, no?
Yes, sir.
So that means
Forms around 8 years should have been ossified by this age.
What is a simple way of confirming whether it is normal or not?
Trochlea.
Hmm?
I don't know, sir.
It's a very simple thing. He has a normal limb. If you think there is some abnormality there, then you can take the X-ray of the other limb and see
Yes, sir.
whether it is comparable or not. Huh?
Yes, sir. Yes, madam.
sir, what is the plans are now? So
My plan for this patient would be, first of all, calculate the preoperative planning with calculation of the deformity, which according to clinical measurement was around 30 degrees. And this patient will most probably need another osteotomy at the supracondylar level to correct the cosmetic deformity with implant removal and most probably a lateral closing wedge, a modified French osteotomy.
So what is the indication of surgery now?
The main indication of the surgery is the cosmetic deformity which is affecting the patient. Also, there could be long-term consequences of the deformity in form of early osteoarthritis, and ulnar nerve palsy can occur in rare cases.
So for cosmetic reason, you will operate again.
Yes, sir.
Okay. What the patient wants.
Yes, sir. Patient is ready to go for the surgery if needed for the cosmetic problem, sir. He
So
is yes, sir.
what caution you will give to the patient or patient attendant?
After the surgery, sir.
Yes.
There is one failed attempt has already been done. The surgery could it is a resistant deformity, so it might not get corrected after the surgery. First thing. Second, there could be a rare incidence of infection or neurovascular injury also.
Any important thing?
And there can be a operative stiff elbow also.
Yeah, so functional improvement, functional range of motion may in fact may decrease after that. Okay, so patient should be ready for that.
Yes,
okay.
Sir. Yes, sir.
Yeah.
So always in elbow, before touching, we should know that the range of movement is improved. After surgery, every time you have to better tell the patient and the relatives that there is a chance of restriction of movement. If they are agreed for that, it is better to touch later after that. Yes, sir.
Yes, sir.
So you told you will do a modified French here again. What is the problem issue with French and modified French? What's one of the thing that we want to avoid by doing these closing wedge osteotomies? So we are shifting to other osteotomies. No. What happens?
There is
No, what is the common complication of French and modified French osteotomy? Which other osteotomies can correct that?
Sir, there is a prominent lateral bump which could be palpated after the osteotomy, which troubles the patient.
So, what is lazy as deformity or curve?
I don't know.
Which you get after this correction with the French. What are other osteotomies in supracondylar fracture?
The other osteotomies are they can be a step cut osteotomy. There can be a DOMS osteotomy, and we can also do a medial opening wedge osteotomy.
What is pentalateral osteotomy, which some surgeons they describe and did, and that helped in correcting the lazy S curve?
I cannot recall at this moment, sir.
Yeah. So, common finding after doing the French and or the modified French osteotomy is that the post-operatively after union of the osteotomy, the patient gets the lazy S curve deformity or that cosmetic, that reason is there. So the pentalateral osteotomy that corrects that, the quadrilateral and pentalateral osteotomies. But it is a complicated osteotomy. You have to calculate so many, make the angles, templating, everything. Okay.
Okay, sir.
Yeah.
So to avoid the lateral condyle prominence, you can do other osteotomies like Professor Aditya sir said. You can go for step cut, dome, or modified reverse step cut. If you are doing a modified French osteotomy, you have to immediately translate it. Otherwise, you'll have a lateral condyle prominence. Okay. So what kind of osteotomies you prefer in MMC, sir?
You are asking me?
No, sir. In Madras Medical College.
MMC.
Okay.
We
Yes.
generally do in the lateral based closing wedge. The
Okay.
problem in lateral based posting, which has seen, there will be a lateral bump. No? Most of the time,
Yeah,
you will end up with
yeah.
a lateral prominence. To avoid that, we may slightly displace the distal fragment.
Medial translation of the distal fragment.
That's what we
Okay.
CMC they do. Some of the CMC results we started doing like that, sir.
Okay, sir. Okay, good.
So there is one small PPT presentation. Shall I put it and conclude, sir?
Yeah, please, sir. Please.
Only 5 slides. Make it fast.
Take it. So Arjit is done. No?
Thank
Thank
this
you, sir.
presentation is very nice, sir. Very nicely presented. Very good case for short case for demonstration. I appreciate the post graduate who has done very nicely. This is very useful for our post graduates also. They all learned some few important points from Professor Aditya Agrawal as well as Dr. Sudesh as well as from Professor Nirmal and Karthik. Thank you, sir. Thank you. Dr.
Thank
Ramesh
you.
Babu, sir.
Thank you, sir.
Dr. Ramesh Babu here or left? Sir,
Hello, sir. Am I audible?
yeah, quickly present this.
Sir, hello, sir. Am I audible, sir?
Yeah, yeah.
Yes, sir. A 13 years old female child presented to the OPD with complaints of limping and shortening, sir. She had a history of forceful kicking while playing football 2 years before, sir. And she was able to walk with pain and limp immediately after the incident for up to 2 months. After 2 months, due to increase in pain and intensity of pain and limping, she went to the native treatment, sir, where she had a plaster application for 4 months, and she was advised to weight bear along with the plaster after 3 months. Now, patient after 2 years came to the OPD with complaints of limping and shortening, sir. On examination, she had no fixed deformities in the sagittal plane, sir. But the flexion was reduced, sir, compared to the opposite side. Hip flexion was up to 90 degrees, sir.
You're not audible.
Sorry for the interruption and small technical issue. Just we'll resume another 5 minutes.
Okay.
2 minutes.
Sure.
So, yes, sir. In the sagittal plane, the patient had a restriction of flexion up to 0 to 90 degree flexion was available. And in the coronal plane, there was a fixed adduction deformity, sir. 15 degree of adduction, further adduction able to do up to 40 degrees, sir. Next. Rotational deform in the rotational with hip in extension, patient was able to do up to uh, neutral on the affected side, and the external rotation of up to 40 degree was able to achieve, sir. But with the hip in flexion, the rotation is patient had a fixed external rotation degree of 15 degree, and further external rotation up to 60 degrees was able to achieve. This was the X-ray.
Yes, sir. Any comments, sir, on this?
Patient for clinically, the patient had a chronic stable Coxa vara anatomical diagnosis. With the clinical findings, my anatomical diagnosis was Coxa vara, most probably due to chronic post-traumatic slipped capital femoral epiphany. Stable slipped capital femoral.
Okay. Metabolically, the patient is normal, huh? You worked out. Metabolic profile and no other things.
No.
Yes, sir. Other than this hip, any patient does not have any other issues. Her BMI was under normal limits, and she was 14 years old female child, sir. Her menarche was everything was attained at normal. No metabolic issues, sir.
Yeah, okay. So even your clinical examination, when you're presenting, we were thinking about a slip actually. So there was fixed in external rotation, and we were able to demonstrate further external rotation, but you're not able to internally rotate. So, and there is a history of like kicking a football. So it looked like we thought that this could be a slip actually. That's what you're showing. Okay. You can proceed actually, like.
So far we are at this stage only, sir. We have not planned our treatment.
Okay.
Our plan is to do a osteotomy at the subtrochanteric level and do a colectomy of the cam lesion. That's the plan. What's your suggestion, sir, for this?
Yeah, you like what we usually do is we used to have an axial image before going for a procedure in the form of either a CT or an MRI. Actually, there is a controversy about getting an MRI. Some people may do or may not do, but we usually do. And you can also see some arthritic changes that's going on the lateral aspect of the site where the metaphyseal area is getting impinged actually. So we just document everything. We get an MR. You just you have the MRI actually. Great. So it's totally posterior. Then thing. Okay. So there are two ways. Like what we do is even in like these cases, we go for a modified triplane trochanteric osteotomy, and you can fix the capital physis before going for the osteotomy on the same setting. Actually, you don't need to do it on two settings. Actually, that is how we manage it here.
Okay. So you do safe surgical intervention or only subtrochanteric?
Like we do counsel the parents, and when we talk about the risk of avascular necrosis, many of them like they are against going for a safe surgical dislocation. We have cases of safe surgical dislocation, but the most commonly done procedure is a triplane osteotomy for in PGI. What we do, yeah.
Okay, sir. Thank you, sir. With this, I think we come to the end. Dr. Professor Sudesh, you want to add anything, sir?
Okay, here's what we do.
Yes, sir. Overall, general, you want to tell anything about our program, sir? Is it worth?
Yeah, it's a great learning platform actually. So it's good actually, and we would like to be continuously associated, and would like to. So it's a distribution of knowledge on either side actually, and it's a great learning platform, especially for the residents actually. So whatever my residents here are like, they have benefited actually, and it's good so that different minds come into play, and like because they are going to get examiners with different viewpoints. So it's always good to have a combined session actually. And it's good, very good actually. And we now with the advance of technology, we are able to demonstrate everything and in a faraway patient. So it's very good thing actually.
Yes, sir.
And I would like to thank you all for inviting us on everyone from the part of everyone from Professor Aditya sir is here, Professor Sudesh, Karthik and myself. And just a small thing, we are doing a surgical workshop on 18th of October. And this is going to be on post-septic sequelae and management as well as live surgical demonstrations. So if you find an hour, like I know Dr. Pasupati is also a faculty in this, so I would like all of the other residents also to participate and get benefited from this. And thank you for having us here.
The company people are there to honor you, sir. Please, one last. Hello.
Yeah.
Yeah. That's fine. Screen வருதா?
Hello. Please put the camera start. Okay, just tell him, sir, first Aditya, sir. First Aditya, sir. Aditya, sir, first.
So, ROCC want to recognize your service for this program, so we want to honor you. Unfortunately, we are not able to reach Professor Aditya.
Hello.
Yes,
Yes,
sir.
thank you.
We are able to see you, sir.
Yeah, thank you so much.
Yes, sir.
Yeah.
No.
Sir, thank
No.
you. Thank you very much for joining this platform. And I request to Pibam sir and Karthik sir and Nirmal sir to receive the honor for Dr. Aditya Agarwal, Aditya sir. Especially sir has came. Sir, please came and receive the regard of honor on behalf of Aditya sir.
So on behalf of MMC, I
And
thank
then
Professor Aditya Agarwal, Professor Sudesh, and Dr. Nirmal and Dr. Karthik for their wonderful contribution for this ROCC program.
Thank you. Thank you so much.
Yes, sir. Thank you, sir.
I request to Nirmal sir, please. I request to Karthik sir, please. I thank Team MMC for an wonderful show. I want to.
So with this, we conclude, sir. Thank you very much. We'll meet
Thank you,
again
sir.
with such programs, sir. Thank you, sir.
Thank you, sir. Thank you, sir. We
Thank
want
you.
to collaborate in future also with MMC. And it was a wonderful show by Team MMC. Thank you.